So actually, we have two last short presentations which should open to collaboration. The first one is on the use of ciprofloxacin in human and the possibility that it accelerates aortic aneurysm. And Scott Lemaire should present us some data in Marfan mice. So if Scott is available.
He's there. There you go.
Thank you.
Good evening, everyone. Are my slides showing up okay?
Yes.
Great. Well, thank you for the invitation to present this work. As many of you know, I've been interested in the role of fluoroquinolones in exacerbating aortic disease, and we've previously published on concerns related to sporadic aortic disease. Just as way of update for everyone, first of all, I have no relevant conflicts of interest to disclose. In October of 2018, the European Medicines Agency, which is the EU's equivalent of our United States Food and Drug Administration, in October, a couple of years ago, they came out with their specific warnings related to the use of fluoroquinolones in patients that have risk factors or conditions that predispose them to aortic aneurysm and dissection. And they included in those warnings Marfan syndrome and vascular EDS. 2 months later, the FDA followed suit and released their warnings, again warning against the use of fluoroquinolones in patients who are at risk for aortic aneurysm, including those with Marfan syndrome, Ehlers-Danlos syndrome, or other genetic forms of aortopathy. Importantly, though, despite these recommendations from the FDA and the European group, there are no data supporting any deleterious effects of fluoroquinolones on the Marfan aortic wall or in any other genetically triggered aortopathies. So because of that lack of data, we asked the question, can fluoroquinolones indeed trigger aortic complications in the setting of Marfan syndrome? And so to address that question, we performed experiments to test the hypothesis that ciprofloxacin exacerbates the development of aortic aneurysm and dissection in a mouse model of Marfan syndrome. So what we did is we used the 1041 fibrillin 1 mutation mice. Many of you will be familiar with this model. It was created and popularized by Dr. Dietz's lab at Hopkins, and this is an example from one of their early papers showing on the left the wild-type mouse in the normal aortic diameter is shown in the white triangles, and in comparison, the fibrillin 1 mutation mouse has severe aortic dilatation involving the aortic root, ascending aorta, and up into the aortic arch. And then down below, you can see the normal elastic fiber architecture in the wild-type mouse on the left compared to the severe fragmentation and disorganization of the elastic fibers shown on the right. Now, despite developing these aneurysms, this particular mouse strain actually is expected to survive. And when you look out at 8 months, again, this from the Hopkins lab, more than 90% of the mice are still alive. So they develop these aneurysms, but they don't tend to dissect or rupture, at least not within the first year. So what we did is we took these mice, they received normal diet, and they were randomized to either receive ciprofloxacin or vehicle by daily oral gavage. Now, no, we gave the drug for 4 weeks, and I think there's valid criticism related to that I'll address when we go over the results. But we wanted to be sure that exposure, even long-term exposure, wouldn't cause aortic manifestations. In addition to the Fibrilin 1 1041 mice. We also included as controls the littermates that also were randomly assigned to receive Cipro or vehicle for 4 weeks. And what I'm showing here are examples of echocardiograms done in the mice 4 weeks after exposure. And this is one of the littermates, and you can see the aortic root there in the yellow crosshairs in the normal diameter, normal morphology of the aortic root. Also, in the littermates that received Cipro, no difference in the root, very normal appearing aortic root diameter. As you would expect, in the Marfan mice that receive vehicle, we see evidence of early aortic root dilatation and that characteristic morphology that you would see in a root aneurysm in the presence of Marfan syndrome, and a mild increase in diameter. However, in the Marfan mice that receive ciprofloxacin, as shown in this example, we saw evidence of severe aortic root dilatation extending up into the aortic arch and massive increases in diameter. This slide shows the diameters and at the 3 different time points. So first, the baseline diameters, as you can see, the green and the purple dots are the littermates, so the non-Marfan mice. The blue mice are the blue dots are the Marfan mice that receive vehicle, and then the red dots are the Marfan mice that receive Cipro. And you can see, as expected, no major difference at baseline. 4 weeks after exposure, we found that there was a significant increase in aortic root diameter among the Marfan mice, particularly those that received fluoroquinolones. And this carried out to 8 weeks. And in fact, this doesn't adequately describe the situation because many of the mice actually died between the initial exposure and week 8, and they all had huge aneurysms, and so many of those are not included here in the week 8 data. But you can see significantly dilated aortas in the Marfan mice that receive Cipro. And here are gross examples. Here is a littermate, the normal aorta, as you can see at the yellow triangle. In contrast, here is a Marfan mouse that did not receive ciprofloxacin. You can appreciate the mild dilatation beginning near the root and extending up into the ascending and proximal arch. In contrast, here is a Marfan mice that received ciprofloxacin, and you can see the large dilatation and almost a translucent aortic wall. And here's a better photograph of that, and then the corresponding histology showing the thinned out anterolateral aortic wall and that sort of odd sort of bulbous region coming off of the distal root portion. So looking at disease severity in these graphs, the blue bars are the Marfan mice that received control vehicle, and the red bars are the Marfan mice that received Cipro. Exposure to Cipro increased the risk or the incidence of aortic dissection or rupture from 25% to 47%, and specifically increased rupture from 5% to 25%. And this translated into decreased survival in the mice that received fluoroquinolones. As you can see in the blue, much like the data from the Hopkins lab, the Marfan mice tend to survive without catastrophic aortic events, if not provoked by some external challenge. So importantly, to my point earlier, it's a fair criticism to say we gave a much longer dose of a much longer time period of exposure to the antibiotic than would normally be used in patients with common indications for fluoroquinolones. But note here that more than half of the deaths actually occurred within the first 14 days of exposure, and you can see how several of them dropped off within a week, suggesting that even short-term exposure can cause catastrophic aortic events in the background of Marfan syndrome. And these are examples from mice. This mouse received fluoroquinolones and died 20 days after exposure, and you can see the large hematoma in the pericardial space on the left. On the right, after cleaning off that hematoma, the forceps are pointing to a defect in the ascending aorta there at the site of rupture. Here are additional examples, 7 days and 13 days after exposure, and this mouse died 94 days after exposure of rupture. And when we remove that aorta, you can see the large aortic root aneurysm and dissection extending through the arch into the proximal descending thoracic aorta. And here's that aorta at 3 months compared to aortas from the other 3 groups at 4 months. And you can see the massive increase in severity in that example. Looking histologically, we found that the Marfan mice that received ciprofloxacin had marked degeneration of the elastic fibers, well above what would be expected in the Marfan mice without fluoroquinolone exposure. We also looked at lysyl oxidase, which of course is a really important copper-dependent enzyme that is involved in cross-linking and stabilization of collagen and elastin. And importantly, the use of BAPN in mice, which is a LOX inhibitor, creates aortic aneurysms and dissection in both Marfan and in wild-type mice. And then there are families with familial thoracic aortic aneurysm and dissection in whom genetic variants in the LOX gene have been identified. So this is an important potential target. And we found that the Marfan mice that received fluoroquinolones had a reduction in LOX activity. So the LOX, we believe, is meant to increase its expression levels in the setting of aortic stress or aortic damage, and in the setting of fluoroquinolones, unable to do so, and so you end up with actually much lower levels of LOX than you would like when you're trying to promote remodeling of the aortic wall and cross-linking of the extracellular matrix components. We also found changes in protease levels. The matrix metalloproteinases, such as MMP9, can degrade the various components of the aortic wall, in particular collagen and elastin. And we found that exposing Marfan mice to Cipro increased the levels of MMP9 as well as MMP2, another protease. And we looked at this not only in terms of expression, but also in terms of zymography showing increased MMP activity. And finally, of course, smooth muscle cell loss is another important aspect of medial degeneration in Marfan syndrome, and we found evidence of increased apoptosis in the aortic wall of these Marfan mice that received Cipro. So in conclusion, ciprofloxacin accelerates aortic root enlargement and increases the incidence of aortic dissection and rupture in Marfan mice. Cipro may promote dissection and rupture through several mechanisms, including decreased LOX exposure, increased protease activity, and increased smooth muscle cell death through apoptosis and perhaps other forms of programmed cell death. These findings, we believe, substantiate that ciprofloxacin and indeed all fluoroquinolones should be avoided in patients with Marfan syndrome. This has been accepted for publication in JTCVS and is actually currently impressed with, I think, 4 or 5 commentaries going along with that related to how this might translate into changes in clinical practice. So I'll stop there after acknowledging the terrific lab team that has done all of this work, particularly my colleague for the last 15 years on the left, Dr. Ying Shen, and acknowledge the sources of funding for the work that I've presented this afternoon. And with that, I'll end, and I look forward to any questions or discussion during the remainder of the session. Thank you very much.
Are you seeing my presentation okay?
Yes.
So we've tried to look at the possibility of gene modifiers on several traits in vascular Ehlers-Danlos syndrome, together with Anne Legrand and people from not only our reference center, but also people from the National Center for Genotyping and from the Imagine Foundation. Oops. I'm trying to go ahead, which is not easy, it seems. Okay. It's well known that we have the phenotypic heterogeneity in that disease, not only due to the type of variants. We have seen that all along the day. You have here, for example, our experience of the age of the first major complication according to the type of mutation. The dominant negative mutation, we have a 50% occurrence of the first major complication at the age of 23 years approximately, compared to 35 or 43 actually for the null variants or the haploinsufficient variants. So undoubtedly the type of mutation in COL3A1 is important, but does not explain everything. And we all know kind of families like this one, where you have the father where was only, for example, some aneurysms and in the arteries without anything else. And he has 2 kids with both of them colonic perforation at the age of 23 or 24. So there is something which, in addition to that, that might explain this difference and this intrafamilial variability too. So what we have tried to do is the following. We have taken more than 360 patients which are recorded in our center with multi-centers, different centers from France collaborating to this study. We have approximately 300 patients with dominant negative variants, more than 200 with glycine substitution. You see that 80 with splice side variants, and 65 actually with haploinsufficiency. We have all genotyped them with an Illumina chip with more than 700,000 SNPs, common SNPs, and more than 200,000 SNPs rare. We have tried to perform a genome-wide association study on 6 phenotypic traits: acrogeria, age of the first severe complication, the presence of a digestive complication, a vascular complication, which is a composite index of the number of affected arteries or the number of acute artery complication. And I just would like, most of our first results for the moment are mainly negative, but I would like to share with you the very positive things that we have found for the colonic perforation. Actually, from the group of dominant negative cohorts, which are the only one to have colonic perforation, we had 54 patients, 41% male, a median of age of onset of 24 years. And we got a locus on chromosome 4, which seems significant, which was significant at the genital Y level, with an odd ratio of 7.5, so quite strong, but you see with a strong confidence interval. And we have other possible loci, which are also suggestive at when we do repeated analysis. So obviously, as for anyone who's involved in genome-wide association studies or genetic studies, when you find this kind of results, it's very exciting, but so at the same time, it has to be reproduced, since you might have some false positive or false negative results. And we do have a cohort which is limited because of this rare disease. And what we would like to get is really a replication on this, and we have a replication proposal for that. So we would like to get patients or DNAs of patients or phenotypes or genotypes with people with known digestive phenotype from different centers or cohorts. We need people with VEDS with dominant negative variants. We think that if we would have approximately the same level of power, statistical power, than we have in this, at a total of 50 VEDS patients with positive colonic perforation, and as much as possible as sex match and controls, we are sufficiently old to have had this complication. So probably more than 35, and not less than 35, but more than 35 years of age, with obviously informed consent. And we would propose either to ask the partners to genotype the target SNPs and to, after that, meta-analyze their results with us, or even to send their DNA in Paris, where we would do the complete Illumina chip with all genome chip, and the genotype would be returned to the partner, and obviously we would meta-analysis at least on the colonic perforation trait, and for that purpose. I think it's a wonderful opportunity to have on a particular rare disease like this one, to have a first insight into modifier genes. And we are very open to any collaboration for that.
I think so. I just want to add my thanks to everybody. It's been great. It was a wonderful turnout. We've had over 100 people participate for most of the day. I know it's very late in Europe, so I just want to thank everybody. We'll be sending out a survey so that you can respond, tell us how we did. I think the format worked as well. I'm glad we got to have some communication. It's hard with the virtual setup, but I thought that was a great meeting, and thank you everybody for participating.
Thank you, Joe. Terrific organization.
Thank you. All the best.
Yes, thank you, everybody.
Thank
Have a
you.
wonderful
Bye-bye.
Good
Bye.
to see everybody.
Bye.
Well, thank you very much, Scott. Very important, interesting results, actually. Have you performed any dose effects of ciprofloxacin on this model?
Yeah, not in mice. We had done that in cells, and not in Marfan cells, but in vascular smooth muscle cells in the first set of experiments when we used a high-fat diet angiotensin II model. For the mice, we use high-fat diet angiotensin II model. We'll look at the effect of Cipro in the context of sporadic aortic disease. And with that paper that was published in JAMA Surgery in 2018, we also did a fair amount of cell work where we did look at dose response effects in the vascular smooth muscle cells. We've not used different doses in the mice, however. So in terms of what threshold of exposure you need, I can't address that. We did select a dose that was based on the dose that would be used for common indications in humans, including UTI or upper respiratory tract infection. Of course, we converted that dose to what would be appropriate for the mouse, given its metabolism. We use a relatively low dose.
There is Mitra Esfandiaric who has a question.
Yes, excellent work. This is very, very interesting. I have a question regarding to the data that you show. It seems that you're proposing that LOX is kind of mediating this destructive effect on aorta. So knowing that, what's your opinion of recommending this medication in normal population for a long term, and also in aging population?
Yeah, it's a great question. And just to clarify, it's reducing LOX activity. The drug is reducing LOX activity, and we show that in the sporadic model as well, and actually looked at that in a little bit deeper in that model. And what we found was in those original experiments, we found in the normal wild type mouse that the level of LOX expression in the aortic wall is minimal, because the aortic wall is not under stress, and there's not this need to sort of remodel and shore up the existing collagen and elastic fibers. When we then exposed the mice to high-fat diet and angiotensin II, and that effect on putting the stress on the aortic wall, we saw LOX jump way up. Again, we think it's a compensation in which the aorta is trying to mitigate the fact that it's now under stress. However, when you stress the mouse and then you gave them fluoroquinolones, that increase didn't happen. And so we suggest that the fluoroquinolones are preventing the LOX from increasing when it's needed to try to improve the strength of the aortic wall. In terms of older individuals, there's the data on that are poor. Right now, all of the data related to the effect of fluoroquinolones and the association with aortic disease come from large retrospective studies using administrative databases. And some of them have looked at age, and some of them have found that the exposure seems to have increased the risk for aortic problems in the older patients. But Melina Kibbe's group from UNC recently published a paper that actually looked at different age groups and found that even in younger individuals, there was an association between fluoroquinolone use and aortic aneurysms and dissections. And so they've actually suggested that that perhaps the drug can cause problems regardless of age. And those were not patients with connective tissue disorders. That was just a general patient population.
Thank you very much.
This fascinating presentation. It's wonderful. It begets a simple question. You can induce an aortic aneurysm.
Oh, okay, stop it.
Can you reverse it? You never think of it. Is there a mechanism for reversal now?
I'm not quite sure what you mean by that in the context of fluoroquinolones. Are you asking whether if you stopped the exposure, whether the aortic damage would regress?
Yes, exactly so. Is there an inciting point where their process cannot be reversed anymore? Or is it a one-way, same thing as you have fibrogenesis in the liver? In cirrhosis, it's a one-way street. The question is, if you stop at a certain point, can you induce a reversal or even stoppage of the process?
Yeah, I can't answer that question. I think it's a great question, and it's common to have the question, what if you only have a really short exposure, let's say 5 days, is that going to be enough to cause damage? We don't know. We don't know, particularly in somebody without aortopathy. That data don't exist.